Good afternoon, and thank you for joining us today in this Image Challenge Livestream event from Retinal Physician. My name is Marianeli Rodriguez, and I'm a retinal specialist here in Massachusetts. I practice in vitro retinal associates. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We'd love to hear your thoughts online. You can find us on Facebook, LinkedIn, YouTube, Instagram, and Twitter. You're also welcome to write in the chat and share your comments during this event. And I'm joined today by Dr. Karen Jeng-Miller from Atrius here in Massachusetts. And I know Karen from my fellowship. She was a resident when I was a fellow at Mass Eye. And I always love catching up with her, especially in the OR, where we share many days side by side. And welcome to the live stream, Karen.
Thank you so much, Mari. It's a pleasure to be here. Thank you for having me.
No problem. So this is going to be a super casual discussion, Karen. I want to pick your brain on this very common condition that we all see, but that is also a poorly understood condition with a lot of controversy. And so if we can pull the images from the fundus photo. So this is a 33-year-old gentleman with a chief complaint of blurred vision in the left eye. His vision at the time was 20/40. He had normal intraocular pressures, had normal anterior segment examination. And these are his fundus photographs and his autofluorescence. So if you can walk us through this, what jumps at you here?
Absolutely. So on the left, where we have the fundus photo, I'm drawn first to the area of RPE, retinal pigment epithelium modeling that he has right centrally. The vessels otherwise appear normal, and the optic disc appears normal as well. And this area of RPE modeling correlates on the autofluorescence to our right with this area of hyperautofluorescence that we can see right centrally.
Yeah, and so we saw that, and we got an OCT, and that we can be seen here in the next image. Right. And if you can, just tell us what jumps at you.
Absolutely. OCT is beautiful for imaging this. And so you see here subfovally, there's an area of serous subretinal fluid. And you also notice that the choroid is quite thick. We can't really see where the sclera is. That tells us usually that the choroid is thick in this person.
That's great. So we post a poll to our viewers, and here you can see that the diagnosis, 93% of them said that it was central serous chororetinopathy, and you were kind of heading us into that direction, correct?
Yes, I think that I would agree with that choice. I mean, all these choices could be valid choices. It could be central serous chororetinopathy, often can be confused for age-related macular degeneration, the neovascular kind. So it is really important to kind of differentiate between it, because the treatments can be quite different and the prognosis can be quite different between those two as well.
Right. And the age, the age difference, he was 33, so unlikely to be age-related macular.
Right.
So when you see a patient like this coming into your clinic, what are the things that, you want to talk to this patient about? What are the sort of questions that you ask them when you meet them for the first time?
Absolutely. So I think you made a really good point that I first look at the age, because usually you find this in younger men, younger to middle-aged men. Usually when they're a little bit older, I get a little bit more concern for macular degeneration, especially because they're usually drusen involved that you see on the OCT too. And so the two top questions that I ask people are, what kind of personality do you consider yourself to be? Are you a type A personality? Are you a little bit more stressed than the general population, you would say? And then and any use of steroids, inhaled, topical, injected, like in the joints. So I think those are two important kind of demographic factors to tease out to help lead you in the right direction for diagnosis.
Yeah, so those are kind of like the first questions I ask. And I also ask about kind of like triggers as well. One of my patients with acute CSR was the father of a newborn, and he was like not sleeping at all. So I was like, okay, well, that's probably your trigger right there, like lack of sleep. And then I had another one that was a big drinker. And actually when he stopped drinking, his CSR got better. So there's, as you mentioned, stress or any triggers of stress can be associated with this. So we always want to tease those things out.
Absolutely.
And you talked about steroids, but I think a lot of patients, don't think of the steroids that they're taking as like, steroids, you don't, unless you mention, oh, do you have allergies? Do you use nasal steroids for that? And they're like, oh yeah, after you ask
Right.
about steroids and they said no. So those are like really, really good points that you mentioned. So in terms of, we have the diagnosis. It's pretty straightforward. So how do you approach a patient like this? Do you observe it? Do you jump to treatment? What do you do?
It's a good question. Central serous, like you said, is kind of a poorly understood condition, and so, but we do know about it is it waxes and wanes. So usually, if it's the first time that I'm seeing someone and they don't really have that many, and they haven't noticed this for an extended period of time, I kind of counsel them on this will most likely resolve by itself. You might have recurrences, you might not have any recurrences. And so usually I say, let's observe this for now. And then we'll usually check in about 3 months to recheck things. And then I give them everyone wants to say, where are we going? So I give them a little heads up into the future on if this is persistent, there are treatments that we can offer for this. One of the mainstays is photodynamic therapy, PDT. And the one thing I try to make sure I tease out is that there's no underlying choroidal neovascular membrane associated with this, just to make sure that they aren't a candidate or need anti-VEGF for it.
Yeah, so that's great. I totally agree with you. Observation is usually my go-to initially. And, each patient is a little different. I try to read the room in terms of like when I will see them. Some people are so anxious about this that I think that they need a little hand holding, and I have them come back in a month. Some of them are like, it's fine. It's a little blurry. I don't mind. And then I have them come back in 3. So depending on the patient and how stressed they're about it, I will see them a little sooner or a little later. And I don't know if you always do 3 months or, do you go by kind of like what the patient, you feel the patient at all?
I absolutely agree with that. A lot of medicine, I think the art of it is just reading the patient. And there are some people, when they're more type A personality and stressed, they're obviously going to be probably more anxious. So I will offer shorter follow up, definitely for people who seem a little bit uncomfortable with the average 3 months that we could do for most patients.
Yeah. And then, you mentioned that a lot of times this goes away on its own. And I think that that's one of the big challenges about the trials and the follow-up for central serous,
Oh, yes.
because, so many of them get better on their own. So the placebo effect is great on these patients. So it's really hard to prove that your therapy actually works because a lot of them get better on their own. So, I always tell the patients this, that, a lot of times it's going to get better on its own. And, there's no, set in stone therapy for central serous. A lot of things are, almost like trial and error. And some things may help a patient and may not help the next one. And I don't know if that's your experience as well.
I agree. I mean, there's so much on the internet that people read too about like there's different things that have never been clinically proven to be. That's why it's not clinically approved for, like eplerenone, mineralocorticoid inhibitors, and so there's not one thing that you can say this is what we should do. But there are things that if people want to try, usually if they're healthy enough, it doesn't hurt to have a short course and see if it does help them. And like you said, it could be the placebo effect. If it works, it works.
Yeah. Do you ever do eplerenone? What's your approach to that?
I usually don't, because the studies have shown that it wasn't better than just a placebo. And so I do let them know that there are anecdotal reports of different types of medication out there. Mifepristone, I think, is another one too. And if they like to try it, I'm open with them, but nothing has been really proven to be super helpful for people. And then if this persists, I think people mostly turn to PDT rather than going through these other treatments.
Yeah. So, I guess my approach is a little different, and you'll talk to different retina specialists and they'll all have a different opinion about this. And I agree, the Vichy trial in 2020 that was published in the Lancet, had about 57 patients in one arm of eplerenone, and the other one was placebo. And in 12 months, they didn't see a difference. And they argued at the end that, ophthalmologists that are putting their patients in this medication really should stop doing so. But I can tell you that I have some patients that have observed. They don't want to start anything. They don't want to do PDT. And then I start eplerenone, and within a month, fluid goes away. So I think that, at least anecdotally, some of my patients have gotten better. So I still offer it as a possibility. I do tell them that, the results of the trial. So it's not like I keep it away from them. But I said, anecdotally, I do have some patients that get better, and I offer it to them if they're ambivalent about laser or other more, focal therapies that we can offer. So that's something I do sometimes. And then, what's your thought about anti-VEGF therapy for this?
I do, if I'm concerned that there is a CNV, I'll get an OCTA and an FA. OCTA is great. It's non-invasive. And sometimes even the FA can be very difficult to tell if there's a CNV hiding under there, especially in the presence of a ton of subretinal fluid. So I really only offer it if I'm very concerned that there's this choroidal neovascular membrane hiding under there. If there isn't, I don't really see a huge role for it when it's just simply, increased vascular permeability and then decreased RPE function in central serous.
Yeah, so I should say that I do offer anti-VEGF to my patients as almost like a trial of anti-VEGF to see if it works, and I have them come back usually in 2 weeks or something to see if it improved. And I would say I'm talking about the patients with chronic fluid, not the ones that are, we ruled those out. Those got better under observation. We're talking about the ones that are not getting better 3 to 6 months later. And in a good chunk of them, also the fluid improves, even if I didn't see apparent CNVM in the OCTA. And I wonder a lot about these patients. If, sometimes they have an occult CNVM and we're not catching it. I'm not really sure, but I do see it that in some of them they do get better.
And I think it's hard to tell. I think it's just basically, like you said, it's a lot of anecdotal reports, and so people want results. And so these are all things we can offer them as long as we educate them about the risks and the benefits of each one. A lot of this can be more patient directed rather than like true, clinical evidence, like clinical evidence, which we have a lack of.
Right. And then, we can talk also about the role of CNV and how, pre-existing history of CSR also increases the risk of CNVM. And that's, we see it quite often in patients that, have a history of CSR, and then 10 years later, you see them with a hemorrhage, and it's obviously a CNVM, and they respond very nicely to anti-VEGFs. That's something that I also tell them, tell all my patients when we're starting on this journey. So.
Absolutely. I think it's a really good point. It's a disruption of the retinal architecture and can disrupt Burke's membrane. So there's always a CNV that's possible. And you make a good point on how when people have CSR for a very long time, you risk RPE atrophy later on, and that in itself can cause some permanent vision damage. So you want to obviously try to avoid that. So it's good to have things in your toolbox to offer people, even if it, again, there's no standard treatment, I would say, for central serous.
Yeah. So you then mentioned PDT, and this is what our patient, what we offered our patient. And actually, this is a patient that I left it to the end, but it's a patient that you referred to me. And PDT is not available, in every practice and in every office. And so sometimes we, refer patients to each other depending on whether we have the laser capabilities in our office or not. So. This patient, as we discussed, he was 20/40 initially. We did a PDT with verteporfin, and he got better in terms of the subretinal fluid. a month later, but his vision was not better, and he was very upset about that. But 3 months later, his vision was significantly better, and the fluid was better, and he was happy. So you kind of have to be patient with these patients and walk them through. It's a journey. So I don't know what your experience is regarding this.
Right. Well, thank you so much, first of all, for taking on my PDT patients. We don't have PDT at the sites I practice at, so I'm always happy to refer them to an excellent clinician like you.
Thanks.
And so I agree. Yeah, like I think the important thing for counseling about PDT is it's not instantaneous. It takes time. And so the vision often follows the anatomy resolution. So people might be impatient with it, but you can, just from experience, just kind of counsel them that things likely will get better. Nothing's ever guaranteed in medicine, but it is something that has been shown to be very efficacious for people who have chronic fluid like this.
Yeah. So, I mean, that's important what you said, because, nothing is in central serous. It's not like when you're treating, wet AMD with Avastin, right? That you're always expecting at least some response. Here, it can be frustrating sometimes. I saw another patient today that a month later, he's actually maybe a little worse. And so it can be frustrating. It can take time, but, we're dealing with a complicated and hard to treat disease in some patients. So I always tell them that right before I do the laser, that a lot of people have a great response like here, but not always.
Right. And they can develop new hotspots. And so sometimes you need repeat PDT for it. And that's something that's a hard pill for people to swallow too.
Yeah.
Even so.
Yeah, because for at least for us, when we do PDT, the patient needs to get an FA for us to find a hotspot. PDT itself, the actual treatment is very short, but they need to get weighed. We need to figure out the dose. All this, it's almost like a 2-hour appointment to get this, and then they need to wear sun protection, hat, long sleeves. Usually I try to do it in the fall and winter. I try to avoid the summer months for this, for the risk of sunburn. So, I mean, it can be hard for them to get this treatment. So, but it works sometimes, and
Yes,
it's very satisfying.
I agree.
So, yeah, this was a great discussion, Karen. I don't know if you want to add anything that you think we've missed in our discussion.
I think that you did a great job covering everything. Thanks for directing such a great conversation.
Oh, thank you for coming. And thank you also for tuning in today. You can leave us a comment online via our multiple platforms. And we hope to see you again in about a month as we discuss another interesting case.